I'm going to discuss Stridor in children with you. I hope you will be able to understand the mechanism and causes underlying Stridor by the end of this lecture. So, first of all, what is the what is the definition of stridor? What is stridor? It is a harsh, high-pitched respiratory sound that is produced by turbulent airflow through a partially obstructed airways at the level of supraglottis, glottis, subglottis, and/or trachea. It has to be differentiated from stridor, which is a low-pitched snoring sound that is produced at the level of oropharynx, nasopharynx, and/or supraglottis. Basically, stridor is a snoring sound, and it is a low-pitched sound, and its level of production is also different. It is mostly produced high above at the level of oropharynx and the nasopharynx, while stridor is produced at the level of glottis, supraglottis, subglottis, and trachea. One thing you should always remember that stridor is a symptom. It is not a diagnosis, it is not a disease. And the underlying cause that is leading to this development of production of stridor that has to be investigated. And that is what I'm going to explain to you today. First of all, we will discuss and try to understand the underlying mechanism of stridor. It can occur at different places in the oral cavity and nasopharynx. Starting, it can be present at the level of the nose in the mouth, but this is less common, or it can happen at the level of the larynx. In the larynx, there can be site of production can be at supraglottic level, the glottis and the subglottis, and lower down in the trachea and the esophagus. Okay, there are first I told you the level of production, the anatomical level of production of stridor. Then I'm going to describe you stridor in terms of phase of the respiration in which it can be heard. If the stridor is audible during the inspiratory phase, it is suggested that the obstruction is at the level of above the glottis. That is, it is supraglottic. While if the stridor is audible in the expiratory phase of respiration, then there is obstruction low down in the trachea. While if it is biphasic, that is, it is audible during both inspiratory and expiratory, this suggests that the level of obstruction is at the glottis or at the subglottic region. So, inspiratory phase, supraglottis, expiratory phase, subglottis and lower trachea, and biphasic is glottic and subglottic region. Diagrammatically, you can say that if it is an inspiratory stridor, the obstruction is mostly at the level of the pharynx and the supraglottis. And if it is biphasic, then it is glottic, supraglottic, and if it is expiratory, then it is low down. Why is stridor, how and why is stridor audible in children? It is very common. It is because the airway of an infant, its lumen is naturally narrow or smaller than that of adults. Therefore, if there is any minor reduction to this airway diameter due to some reason, it can be inflammation, it can be mucosal edema, it can be some foreign object, then there will be a further narrowing obstruction of the airways. As you can see, this airway is quite narrow, and if the top of it, there we have some sort of inflammation or some edema as a result of the inflammation or some foreign body obstruction, then there is further hampering of airflow, and as a result of this obstruction to airflow, the high pitched sound will be produced that we call as stridor. As in this figure, you can see this is the epiglottis, these are the vocal cords, this is the trachea or the windpipe, and this is the arytenoid cartilage. Due to this narrowing, there is an exponential increase in air resistance, which makes it difficult for the child to breathe, and hence a stridor is audible. The upper and the lower airways are small, prone to occlusion by secretion, and susceptible to edema and swelling. The support component of the airways are less developed and are more compliant than the others. Another reason, the ribs are cartilaginous and perpendicular relative to the vertebral column. This reduces the bucket handle movement of the rib cage. In addition, the intercostal muscles and the accessory muscles of respiration are immature. So, first, the airway is narrow as compared to the adults, and to further hampered by this any inflammation, edema of foreign body, there is narrowing and increased resistance to airflow. Then the airways are also smaller in size, more prone to occlusion by secretions and edema and swelling. And the support mechanism that is provided by the rib cage is also less developed, as well as the intercostal muscles and the accessory muscles of respiration are not mature properly. So all these factors combined together, they predispose a child more susceptible to the development of stridor. As a result, they are more reliant on the diaphragm for inspiration. All these factors combined together, they make a child more dependent on the diaphragm for inspiration. Increased respiratory effort causes subcostal standardization and the mechanical efficiency of the chest wall is reduced. High metabolic rate, increased oxygen demand means children with airway compromise can deteriorate very quickly. Also, with a smaller functional oxygen capacity and fewer fatigue-resistant fibers in the diaphragm, there is little respiratory reserve at the time of stress. So, to summarize the basic pathology underlying the development of stridor in children, there are certain anatomical factors: narrow airways, smaller airways, narrow and smaller airways, and further included by some inflammation, edema of foreign body, leading to increased airway resistance, perpendicular position of the rib cages, and improperly developed and immature intercostal and subcostal muscles of respiration, and to top of it, in reduced photoreceptor capacity, fewer resistant fibers in the diaphragm. All these factors, when added together, they are responsible for the development of this high-pitched sound that you term as stridor. And I tell you, it is a very horrifying sound. What are the causes of stridor according to the age and concept of the disease? If you are able to hear the stridor in a new way, then the most commonest cause is laryngomalacia, followed by vocal cord dysfunction. This leads to this is a chronic onset disease. These are followed by congenital tumors, granulopathias, laryngeal web, and congenital tumors. If your patient is a child, then the most common causes of stridor are infections, most commonly epiglottitis, laryngitis, and this is followed by flu, foreign body. These three causes, that is epiglottitis, flu, and foreign body, these are acute in onset, as opposed to laryngomalacia and other vocal cord dysfunctions that are found in the neonatal age group, but they are chronic in onset. Then we have the adult age group, in which again the infections and the trauma are the positive. Then, depending upon the anatomical location, sound and etiology, uh, supraglottic, we have gurgling sound, coarse sound in glottis area. We have a biphasic stridor that is audible both during the inspiration and the expiratory phase. Then we have a subglottic region where we hear the stridor during the then etiologically, we have some congenital causes and the acquired causes. And congenital causes, the commonest cause is macrokinesia, fluid Robin syndrome, macroglossia, Down syndrome, storage disorders, paralytresias, lingual thyroid, and thyroglossal cyst. And if the level of stridor is glottis, then the cause may be laryngomalacia, vocal cord paralysis, laryngeal barrier, laryngoscele, and if it is in the subglottic region, then it is due to subglottic stenosis, uh, trichomalacia, tracheal stenosis, vascular vein hemangiomas, and if it is an acquired etiology, then we should consider venopathies, transitory hypertrophies, foreign bodies, pharyngeal abscess, epiglottitis, and papillomas in foreign body. And for the glottic level, and through tracheitis, subglottic stenosis in foreign body for the subglottic etiologies. There are certain precipitating factors which, if present, they will cause the worsening of the or the precipitation of stridor. If you observe that the stridor worsens with straining or crying, then you should think of laryngomalacia or the subglottic hemangioma as the underlying cause. If the stridor worsens with the child being placed in supine position, then again laryngomalacia and trichomalacia are at the top, to be followed by macroglossia and microglia. And if the mother gives the history that stridor gets worsened at night, then the viral or spasmodic group is the cause. If the worsening is observed with feeding, every time the child is given feed, mother says that this sound gets worsened, then we have to consider tracheoesophageal fistula, tracheomalacia, neurological disorders, and vascular conditions. If there is an preceding upper respiratory tract infection in the history, then croup and bacterial tracheitis are the most common causes. If there is a history of choking followed by stridor, then the number one suspicion should be foreign body aspiration, followed by tracheoesophageal fistula. The associated symptoms that you can also observe, and that can also be a leading clue for the diagnosis. If there is a associated barking cough along with the stridor, then croup is the most likely diagnosis. If there is a brassy cough, tracheal lesion is the cause. If you observe that, or the mother gives the history that there is stridor and there is drooling of saliva from the mouth, then you should consider epiglottitis in at the top, to be followed by foreign body and retropharyngeal or peritonsillar abscess. If there is a weak cry, and this is followed by stridor, then laryngeal anomaly or some neuromuscular disorders should be considered. If there is a muffled cry, then you should consider supraglottic lesion, and if there is history of snoring, then along with the stridor, then adenoid or tonsillar hypertrophy should also be thought of. If there is a history of dysphagia, difficulty in swallowing, then supraglottic lesion is to be considered. If there is past history of some endotracheal intubation in the history, then you should consider that vocal cord paralysis would be at the bottom of the stridor. And if there's birth trauma, perinatal asphyxia, cardiac problems, then again vocal cord paralysis should be considered. If there is some utopia, then you should consider angioneuritic edema, spasmodic mood. If there also should also take family history of Down syndrome and hypothyroidism, psychosocial history to go for some psychosocial stress, and that leads to psychogenic stridor. Every time the child is got some stress, he starts producing this sound. While you are evaluating a child for stridor, there are certain general findings, and then there are certain specific findings. General findings: if you find out that there is associated cyanosis, then you should consider some cardiac cause. Or if there is fever, then there must be some underlying infection. If the child has got a toxic sick-looking child, anxious child with drooling saliva from the stridor, then you should consider epiglottitis. If there is tachycardia or bradycardia, then you should consider cardiac failure and or hypothyroidism. If the child is sitting with hyperextension of the neck, Then the most likely level of obstruction is some obstruction at or above the level of the larynx. As I already mentioned, if the child is seen anxiously sitting with leaning over and drooling, then epiglottitis is your number one diagnosis. If the stridor listens in your prone position, then you should consider laryngomalacia. If the chest findings are during the there, you find that there is prolonged inspiratory phase of respiration, then you should consider laryngeal obstruction. If the expiratory phase is prolonged, then tracheal obstruction should be thought of, and air entry is decreased unilaterally, then foreign body on that side is the number one suspicion. If there are some arrhythmias, heart murmurs, abnormal heart sounds, then there is some structural heart disease. If there are cutaneous hemangioma or septic hemangioma, should be thought of peripheral neuropathy, vocal cord paralysis, urticaria, and neurotic edema, then you should consider some atopy and endometriosis. Now I am going to discuss with you the commonest causes of stridor in children. The first I will discuss laryngococcal bronchitis or flu. This is a viral illness, and the virus typically causes the most common cause of upper respiratory tract obstruction. Most common age group is 3 to 5 years, with the peak being the second year of life. More common in males, and 15% have got a strong family history. Now, what is the pathophysiology? First of all, there is viral invasion of the nasopharyngeal epithelium, and there is local spread of inflammation to the larynx and the trachea. Then this is followed by epithelial damage that causes further mucus production and loss of ciliary function. Then there is edema of the subglottic larynx. A small amount of edema within the ring of the cricoid cartilage leads to decreased airflow. Right? And there is fibrous exudate that includes the lumen of the trachea. So first there is invasion by the virus that causes inflammation of the nasopharynx epithelium. Then this spreads from nasopharynx to the larynx and the trachea. As a result of inflammation, there is epithelial damage, and that causes mucus production and loss of ciliary function. Edema of the subglottic larynx and the cricoid cartilage that leads to further decrease in airflow. This edema, along with the fibrous exudate, partially includes the. So all these factors they contribute to decreased lumen of the airways, and as a result, there is resistance to the airflow, and that produces a harsh, high-pitched sound that we call as stridor. How will the child present in case of laryngococcal bronchitis or flu? There is first of all there will be history of previous upper respiratory tract infection prior to the development of airway obstruction. The child will develop barking cough. The mother will typically give you a history of. She will say that there is a kong kong type person. This is the typical word that is mostly used by the mothers in our setup. So that will also give you a clue plus the history of preceding upper respiratory tract infection. Then there will be losses of voice, and the stridor will be more marked during the inspiratory phase of the respiration, or it will be precipitated when the child is at rest or excited or bored. The symptoms they usually worsen at night when the child is made pre-hyper. And within a week, since it is a viral illness, these symptoms usually resolve in a week. Agitation and crying greatly aggravates the symptoms and signs of the disease. If you make the child agitated or the child starts crying, then there is worsening of the symptoms. Physical examination, we will find an agitated child, an irritable child, and the examination of the pharynx will be normal to some degree of moderate inflammation. There will be slightly increased respiratory rate, suprasternal, infrasternal, intercostal contractions in various areas. The child usually prefers to sit up in the bed or likes to be held upright. Now, how will you investigate a suspected case of croup? It is usually a clinical diagnosis, and there are really no requirement of the radiograph. But if it required, then the most common sign that you will. I hope you are having problem in understanding. If at all you have any problem, you're most welcome to ask, interrupt me, and I will be more than happy to address your problem. If you get an X-ray of the surface of the neck, there will be subglottic narrowing. As you can see in this picture, this is the X-ray of the neck, and this is the subglottic region, and you can very well appreciate that there is narrowing of the trachea just in the subglottic region. Down below, the airway has got a normal movement, but subglottic region due to the obstruction there is narrowing of the airway. That is leading to increases to airflow and strain. How will you manage racemic epinephrine, that is 2.25% solution, that is diluted to 3 ml volume with normal saline, is given through nebulization of 15 minutes, or epinephrine that is in 1 is to 1000 dilution is also given for 15 minutes but along with nebulization. Dexamethasone 0.6 mg per kg IV intramuscular oral is given as a single dose. Nebulized budesonide has proven efficiency. Antibiotics and sedatives are not at all indicated. So you are not supposed to give antibiotic because it's viral illness, self-limiting disease, and sedatives are also highly contraindicated. You will not give any cough suppressor and sedative to the child. Now, the second important cause of stridor is hepatitis. It is a life-threatening emergency due to respiratory obstruction. Affects all age groups of children, but most common in the first 6 years of life. And the organism that is responsible is Haemophilus influenza type B. Other causative organisms they include Streptomonas, Staphylococcus, and Streptococcus. And what happens in epiglottitis, as the name is quite evident, that there is inflammation of the epiglottis. There will be inflammation, intense swelling of the epiglottis and the surrounding tissue associated with septicemia. Clinically, the child will present as an otherwise healthy child who has suddenly developed sore throat and fever, and within a few hours, the presentation, the child presents in their emergency with a very toxic sick note, having difficulty in swallowing, labored breathing, drooling, mostly present as patient finds painful to swallow. Neck is hyperextended to attempt to maintain the airway, and the child may assume a tripod position, sitting upright, leaning forward with chin up and mouth open while pressing. This is the typical position of the child with this is called the tripod position. The child is sitting upright in the bed, leaning forward and supporting himself with the arms resting on the bed, and the drooling of saliva from the mouth, and the child has got a wing sit. There is a brief period of air hunger with restlessness followed by a rapidly increasing cyanosis and coma. Stridor is late forming and suggestive of complete blockade of the airways. Establishing the airway by endotracheal intubation or by tracheostomy is indicated in patients with epiglottitis regardless of the degree of apparent respiratory distress. As I have already mentioned, epiglottitis is a medical emergency and needs to be addressed and managed very aggressively. Um, in general, these children are intubated for 2 to 3 days as the response of antibiotic is very rapid. think these children they should not be examined in the emergency room or in the ward. They should be examined in the ICU setup in the theater where you have uh, experienced person with you, and there is a facility available for intubation. And in this setup, we will go for an endoscopic examination. Um, and as you can see in this picture, this is the normal view that is seen from the endoscope. You can see this, these are the vocal cords, this is the airway, and this is the epiglottis. And compared to this, in case of epiglottis, you can very well compare that how much swollen this epiglottis is. And due to this appearance, it is commonly called the cherry red epiglottis. You can see that it is swollen and red due to intense inflammation, just like a cherry. So, if you compare it on this normal picture, you can very well appreciate the degree of inflammation. Uh, Now, should be the next step? Having examined this, the next step should be getting a lateral view of the cord tissue. And the classical radiograph sign that you see is the thumbprint sign. This is just like a thumbprint. इसको कहते हैं ना अंगूठा लगाना. जैसे आप अंगूठा लगाते हो सेम इस तरह का. This is an swollen, edematous, highly inflamed epiglottis, and when it is viewed in an X-ray, this is the appearance that it normally gives. Normally, it is not swollen, rounded, and enlarged in the normal radiographs. If you are able to appreciate. Now, having diagnosed, what will your steps of management? Now, this child has to be managed and admitted to the ICU, should be intubated and general anesthesia. Urgent tracheostomy can be done if intubation is not possible. Blood culture, culture of the blood and the epiglottis should be collected, but only after you have secured the airways through intubation. Before this, you are not supposed to even examine the fluid. Although you have the suspicion, but the matter of the fact is that you will not touch the patient, you will not make him open the mouth for examination, because once you do, there is such a large degree of incident that the child will immediately hold the breath. Start the patient on the antibiotics immediately for at least 10 days, as most patients have some concomitant bacteremia. Mostly we use cephalosporins, second, third generation cephalosporin, or miropath. Most children recover fully within 2 to 3 days, and followed with this, there is one important thing is that within prophylaxis. This is given to all the house members, including the child is 4 years of age and completely immunized. Younger than 12 months of age and having completed primary vaccination of immunocompromised. So the important message that you should remember from this disease, that from this account, is that minutes come to evidence. So you have to be very quick, you have to be very vigilant and aggressive in your management. Now, the third important cause of stridor is foreign body expiration. Most commonly seen in children under 3 years of age. They swallow, breathe in a foreign body, the coin, marble, considering the button, teeth. This one, as they are always very intrigued and interested. Children are there with request, they say, for any foreign button beads. Despite a strong gag reflex, the child's airway is more prone to obstruction than an adult. So it is more serious complication of foreign body, especially complete obstruction of airway, leading to severe degree of stridor, and that can be recognized in the conscious and sudden respiratory distress followed by an ability to speak or talk. Clinically, there are three stages: the initial event, when there is a violent paroxysm of cough, choking, gagging, air obstruction, then there is an asymptomatic interval in which the foreign body gets lost, reflex fatigue, and the irritating symptoms subside. This is the most treacherous stage. It is during this stage then the child is poor asleep, and the possibility of foreign body aspiration is minimized. This the physician will not be able to consider because the child is not that much irritated that he was in the first stage of aspiration. This is followed by the third stage of complications, the foreign body, the obstruction, erosion, infection, leading to other life-threatening complications. Stridor is commonly present with upper airway or upper tracheal foreign body. There is an indication of prompt intervention, and 50% of the children have inspiratory stridor or expiratory reason with evolution of expiratory phase when median to post bronchial. They may present with hoarseness or of voice and stridor if the traction is at the level of the larynx, or may present with wheeze if it is at tracheal level, or cough or unilateral wheeze, decreased breath sound if air through the foreign body has lodged into the mucous membrane. How will investigate? Naturally, we'll go for the X-ray of the neck and the chest, AP view of the neck, and the lateral view of the soft tissue of the neck. Uh, Checking two views of the foreign body, they help to determine its location and include the presence of superimposed multiple foreign bodies. Most foreign bodies are radiolucent and they may show signs of an infraglottic capacity or swelling from airway inflammation of PA and lateral leg radiograph. This is the AP view, and this is the lateral view in which you can see very well appreciate this foreign body. This is radio played, and that is our definitely we are able to appreciate the presence of foreign body. Then you have flexible bronchoscopy. If the clinical suspicion is high for body aspiration, flexible bronchoscopy should be performed for definitive diagnosis and treatment. Then you have CT scan that will detect some papillocystic atelectasis along with consolidation, and also detect the foreign body within the region of the brachiobronchial tree, and the three-dimensional position of the foreign body within the thorax can be appreciated. How will you manage? Most cases of ventilation, they are not witnessed. Hence, diagnosis really depends on high index of suspicion. We need to do a lateral X-ray, neck, maybe chest X-ray. Prompt endoscopic removal of the foreign body with rigid instrument is the treatment of choice. Bronchoscopy is deferred only until pre-op studies have been obtained and the patient has been prepared by adequate hydration and empty lungs. Now, the fourth cause of stridor is diphtheria. It is an infectious disease caused by bacterium called the Cryptobacterium diphtheria. Primarily affects the mucous membrane of the respiratory tract, although it may also affect the skin and lining tissues in the ear, eye, and genital areas. Clinically, the child presents after incubation period of 5 days, and this respiratory diphtheria usually presents with sore throat, fever, malaise, cold, difficulty in swallowing and breathing, and stridor. With the progression of respiratory diphtheria, infected individual also develops. Hello, I hope you're able to listen to me and you're able to hear me. There is development of an adherent gray membrane, which is called the pseudomembrane, over the lining tissue tonsils and the nasal. Extension of the pseudomembrane into the larynx and the trachea difficulty in breathing. The dissemination of diphtheria toxin can also lead to systemic disease causing complications such as myocarditis, visual, management is through diphtheria antitoxin. It is a mainstay of therapy It neutralizes circulating diphtheria toxin and reduces the progression of the disease. Antibiotics are administered as soon as possible to suspected diphtheria patients. They help eradicate the bacteria, stop toxin production, and prevent transmission of bacteria to close contacts. Penicillin and erythromycin are available. Asymptomatic carriers as well as all close contacts potentially exposed to diphtheria also have antibiotic treatment. Now, laryngomalacia is the most common congenital laryngeal and pulmonary infection and the most common cause of spread. Approximately 60% of cases that are seen on the neonatal age group are due to laryngomalacia. And the characteristics of this laryngomalacia is that it is an inspiratory sound exacerbated by exertion time leading to the collapse of glottic structures in the respiration. Symptoms appear within the first 2 weeks of illness. The increase in severity up to 6 months or the gradual improvement can begin at any time. Laryngopharyngeal reflux is common. Laryngomalacia is normally seen with a flexible laryngoscopy. During expiration, the epiglottis is patent and no abnormal sound is heard. Right? As you can see, the child is expiring, the epiglottis is patent, there is easy flow of air in and out of the airways, and no sound is audible. Now, during inspiration, the epiglottis and the arytenoids they collapse and compress the supraglottic and the glottic opening causes inspiration. These are the in case of severe laryngomalacia, surgical resection of redundant tissue can improve the glottic patency even during inspiration. Now, how will investigate flexible laryngoscopy, chest X-ray, brain contrast X-rays, and group bronchoscopy? Management is through expectant observation. Most symptoms they resolve spontaneously and as the child in the airway grows. All you have to do is reassure the parents that with the passage of time, as the child grows and the airways they also grow, probably these symptoms will improve. But in severe cases, surgical intervention may be required and has to be done. That is endoscopic supraglottoplasty for patients with severe obstruction, especially when there are other life-threatening events associated together like heart failure, cyanosis, failure to thrive. Now, subglottic stenosis is an lesser important cause, but you have to also must be knowing these causes. So briefly, I will describe these uh, the subglottic stenosis. It usually develops after intubation or manipulation of the air. Whenever there is history of intubation, after this there will be stenosis at the subglottic level. It is usually continuous. That is, there is no differentiation between the expiratory and the expiratory. You will be able to hear it continuously throughout the course of respiration. It is predominantly inspiratory but often bipolar. So subglottic narrowing on neck radiograph and direct laryngoscopy is seen. Mangiomas are the Boston studies the history of genus mangiomas and subglottic obstruction on neck radiographs. And mangiomas are seen usually on direct laryngoscopy. Vocal cord cysts they lead to hoarseness of voice, chronic irritation to vocal cords, or airway instrumentation. Cysts are usually visible on laryngoscopy. As you can see, there are three causes of Stridor. In the first one picture, you can see there is severe degree of subglottic stenosis. So much so that there is a very little movement depth of the airway for the smooth flow of air through it. As a result of this narrowing of obstruction to the airflow, there is resistance and reduction of this high pitched sound that we call as stridor. Then the second picture shows a subglottic image on the right side. As you can very well appreciate, this is uh, there is this imaging vascular swelling, highly vascular, and as a result, there is narrowing of the airway. And further there will be resistance and stridor. In the third picture, you can see a subglottic duct cyst. This is the cyst that is present in the subglottic region. Again, it is occluding and obstructing the lumen of the air, obstructing the passage of the air through these airways, and this, as a result of this obstruction, it's increased resistance to airflow. This increases this leads to production of a very harsh, high-pitched sound that is called stridor. I hope this clear to you. So, in the preceding slides, what I to summarize, what I try to make you understand is what is a stridor. So, stridor is a high pitched, harsh sound that is audible either during inspiratory phase of respiration or expiratory phase of respiration or in both phases. So, in either case, the etiology will be different, but you must remember that in any case, stridor is a symptom. It is never a diagnosis, it is never labeled a disease because it is a symptom that will hint you to some underlying disease, that there is an underlying cause, that will be some structural anomaly, that will be some infectious cause, there will be some foreign body, that is, in all of these cases, there will be obstruction to airflow. As a result of this obstruction, there will be resistance to airflow, and due to this resistance of airflow, there will be production of a very harsh, high-pitched sound that is called the stridor. So, in the end, I will show you a small video, and in with this video, you will be able to appreciate how and can you pick up stridor in a child. I think there's some. So this amount of harsh voices audible. You can be you should be able to uh, constant session, intercostal session, and a very hybrid sound. This, I hope you are all are able to understand the underlying mechanism of struggle, its causes, and how to manage it. If there is any question, I'm more happy to answer. हाँ जी, आयशा, बेटा कोई सवाल है तो पूछो। बहुत इम्पोर्टेंट टॉपिक है ये। अक्सर एग्जाम में आपको एक सिनेरियो आता है, आपने आइडेंटिफाई करना, प्रेजेंटेशन, हिस्ट्री, क्लिनिकल फाइंडिंग्स, आपको बताना होता है कि क्या कॉज है जिसकी वजह से, क्या डिजीज है, क्या रीजन है जिसकी वजह से स्ट्राइडर हो। हाँ जी, कोई सवाल है ये? मैं सवाल पूछूं? हम्म? How will you define strider? Okay. Anyone? मजे कैसे जा रहे हैं? हम्म? अच्छे गुजर रहे हैं? मौसम तो अच्छा है, घर में अच्छा, मजे कर रहे हो? पढ़ भी रहे हो कि नहीं? सब समझ आ गया? Okay, thank you very much. Thank you very much for your patience.